Optimizing Management for Mind to Moderate UC in the Era of Stride, Professor Julajak Limsrivilai. Currently, Professor Julajak is an Associate Professor at Faculty of Medicine, Siriraj Hospital, Mahidol University, Thailand. Please give a warm welcome for Professor Julajak. Thank you.
Good morning, ladies and gentlemen, and good morning, our professors in this room. First of all, I would like to thank Ferring for organizing this fascinating IBD symposium. And it is my great pleasure to introduce Professor Wai-Keung Leung as our speaker today. Professor Leung is currently the Lai Shu Fan Medical Foundation Professor in Gastroenterology. His current position is Associate Dean Research at Wai-Keung Faculty of Medicine and the Chief Director of the Clinical Trials Center of the University of Hong Kong. He has published over 300 articles in many high-impact factors in both medicine and GI fields, including many articles in Lancet, Gastroenterology, Gut, as well as many others. His corpus H index is 70 right now. Also, he is an editorial board member in many journals, such as Endoscopy, Gut and Liver, and etc. And last, he is a current president of the Hong Kong Society of Gastroenterology. Today, he is going to give a talk optimizing management for mild to moderate ulcerative colitis in the era of Stride 2. So please welcome Professor Leung.
Thank you very much, Professor Julajak. Can you hear me?
Yes, I can hear you well.
Thank you very much. I'm going to share my slides. So thank you very much for the invitations. It's my pleasure to give this talk on optimizing management for mild to moderate UC in the era of Stride 2. So we all know that IBD's disease activity is only, particularly clinical disease activity is only the tip of iceberg. That's why we need monitoring tools, including biochemistry, and many of times we need endoscopy and even histological activity to determine whether the patient is in remissions or just not. So that's why the treat-to-target approach have been really adopted in the management of IBD. This approach is relatively simple. If you think about diabetes or hypertension or even lipid, there's a very well-defined target that we want to treat our patients, such as HbA1c, the blood pressures, or the LDL level. So these are very hard, solid outcome or target that we want to achieve. It may be a bit tricky when applied to IBD because we don't have these parameters, we don't have these numbers in treating IBD patients. So we need to identify the target, and if the target reached, we probably continue treatment or even considering the escalation of treatment. But if the target is not reached, then we may have to go back and consider escalating of treatment to achieve that target again. The good thing is about target is that the IOIBD has issued 2 guidelines on what is the best target in managing IBD. In 2015, they published the STRIDE guidelines, and last year, they updated the guidelines with the STRIDE 2 recommendations. So what is STRIDE recommendations in managing of UC? So the endpoint or target that we want to achieve in 2015 in the STRIDE 1 guidelines is basically clinical and endoscopic remissions. Clinical is defined as resolutions of bleeding and normalization of bowel habit. And for endoscopic remissions, they adopt a Mayo endoscopic score of 0 to 1 as endoscopic remissions. And STRIDE 1 biomarkers such as C-reactive protein and fecal calprotectin are only considered adjunctive measures of inflammations and not targets for monitoring UC yet. So here comes to STRIDE 2, which is updated last year. The main difference between STRIDE 1 and STRIDE 2 is STRIDE 2, CRP, and fecal carbotectin are considered formal intermediate treatment targets, but they haven't defined the optimal cutoff for fecal carbotectin yet in STRIDE 2. And symptoms and endoscopy is still relatively the same, except there's some small modification that I'm going to allude to. So in STRIDE 2, the targets are divided into short-term targets being symptoms, intermediate targets being normalization of CRP and normalization of fecal carbotectin to an acceptable range. And in children, it's also normal growth as well. For long-term targets, it's still endoscopic healing, which is considered the relatively long-term target in managing IBD patients. So CRP is very simple. It's normalization of CRP, but fecal carbotectin, they haven't defined a numbers like LDL or HbA1c, but they use a range, they recommend a range ranging from 100 to 250 as an intermediate target for both UC and Crohn's disease. For endoscopic healing, this time they changed from Mayo score of 0 to 1, but to Mayo score of 0. You can see that they're more stringent this time for endoscopic healing. And yet, histological healing or histological remission is still not yet considered a target, even for STRIDE 2, because it's not easy to achieve clinically. So this is the Mayo endoscopic score. I know many of you are very familiar. So ranging from 0, which is basically normal, to just slight mucosal edema or decreased vascular pattern and mild viability as Mayo score of 1. In fact, there are many data suggesting that there's a difference between Mayo score of 0 and Mayo score of 1. And in this meta-analysis, they show that if you can achieve Mayo score of 0, it's about 52% lower risk of clinical relapse when compared to Mayo score of 1. So there's still some significant difference between Mayo score of 0 and Mayo score of 1. Also, in the same meta-analysis, they also showed that if you can achieve histological remission among patients with endoscopic remission with endoscopic score of 0, there's still a 63% lower chance of clinical relapse if you can achieve histological remission. So there's still benefits of histological remission, but it is not easily achieved clinically. That's why they haven't adopted that as a clinical target or endpoint even in STRIDE 2. So what's the optimal fecal carbotectin level? Is it 100? Is it 150 or 250? So let's look at the data. So this is one of the older data looking at in patients who are in clinical and endoscopic remissions. If you have a fecal carbotectin of more than 300, the chance of clinical relapse or flare is much higher if you have fecal carbotectin of less than 300. So obviously, 300 is probably too high, it's current standard, but that study is suggesting that you should be much lower. So how low? So this is a very recent post hoc analysis of study using 5-ASA for clinical inductions of patients with ulcerative colitis. They found that the optimal cutoff concentration for histological remission is probably between 75 and 100 for fecal carbotectin. So if you can achieve that, you're very likely to have, in addition to endoscopic remission, but also histological remissions. And this also post hoc analysis comparing vedolizumab with adalimumab. They found that by week 14, if you have fecal carbotectin less than 250, you're very more likely to have clinical remission, endoscopic remissions, or even endoscopic remissions. So 250 appears to be a quite reasonable number as a cutoff point when using even biologics. So this same study also looking at fecal carbotectin at week 6 after induction therapy. So that if you can have fecal carbotectin level less than 250, the chance of having surgery is much less likely when compared if you do not achieve fecal carbotectin of more than 250 at the end of week 6 after biologics. So with week 6, 250 seems to be a reasonable cutoff point for fecal calprotectin to predict future better prognosis. So this is a very recent AGA proposed clinical practice guidelines. This is still not yet published, and they're still asking for comment. But in that, they also follow the STRIDE 2 recommendation that when monitoring patients for symptomatic remission, they recommend the use of combinations of biomarkers as well as symptoms, rather than symptoms alone. So this is very, very solid. They use a fecal calprotectin level of less than 150 and normal CRP to route active inflammation and avoid routine endoscopic assessment. So they use a slightly lower fecal calprotectin level in their draft of recommendations. So if you have symptomatic remissions, but just found to have elevated fecal calprotectin more than 150, what should you do? AGA recommend endoscopic assessment rather than empirical treatment escalations. On the other hand, if you have symptoms but normal fecal calprotectin and normal CRP, again, AGA also recommend the use of endoscopic assessment rather than empirical treatment adjustments. So I think these are still draft. They may be subject to changes, but this is what has been written as a draft that fecal calprotectin 150 is recommended by AGA. But we are looking forward to the final version, whether they will change this level or they stay on 150. But anyway, between 100 to 250 seems to be a reasonable indicators of remissions, at least endoscopic remissions in patients with ulcerative colitis. So how to practice treat to target for ulcerative colitis in clinical practice? We are all very familiar with this treatment algorithm that we usually start with 5-ASA, particularly in UC, and if patient fail to respond, we add on steroid or immunomodulators, particularly valpirins, and not maybe we consider biologics. So in the AOCC or APAGE recommendations published 2 years ago, when treating mild to moderate UC, they still recommend a step-up strategy to induce remissions by using 5-ASA or even sulfasalazine. And if the patient's, particular patient with proctitis, left side colitis, they recommend combinations of oral and topical treatment together, particularly 5-ASA and sulfasalazine. So this is an AGA review published 3 years ago in gastroenterology. They look at different doses for 5-ASA used in the inductions of remission of ulcerative colitis. And you can see that, in fact, there's a dose response, at least for induction therapy, that if you use much higher dose, usually more than 3 grams per day, the response seems to be better than standard dose or even low dose 5-ASA. So for induction therapy, I think the higher dose of 5-ASA should be used. So if the patient does not respond very well, you may consider, as recommended by the AOCC and APAGE recommendation, the combinations of oral and topical 5-ASA. So again, shown in the AGA meta-analysis, for both for induction and maintenance of remissions, the combinations of oral and topical 5-ASA is much better than oral 5-ASA alone. So there's benefit in using combination therapy, both oral and topical, and if the patient do not respond well. What about topical 5-ASA versus topical steroid? So in this meta-analysis, they found that topical 5-ASA is actually much better than topical steroid, particularly I think for patient proctitis and left side colitis. So topical 5-ASA is actually first line when compared to topical steroids. What's the role of steroid? Nowadays, where we, apart from conventional steroid, there's also this form of steroid called budesonide, which has extensive first-pass metabolism, so they have much less systemic side effects when compared to conventional steroid. The frequently used, particularly older version, the Antalcort, is frequently used in patients with idiopathic Crohn's disease. Now that we have an MMX version, which is a colonic release budesonide, so they're designed to be dispersed in the distal part of the colon, particularly left side colon. So they can deliver to the distal part of colon and particularly useful in patients with ulcerative colitis. In the ECHO recommendations just published this year, the colonic release corticosteroids, namely this budesonide MMX versions, is actually recommended for induction of remission in patients with active mild to moderate UC before you actually consider the use of systemic steroid, particularly in patients with not very severe ulcerative colitis. What's the role of systemic steroid? When will you use systemic steroid? In the AOCC recommendations, systemic steroid is only for induction of remission in patients with severe ulcerative colitis, not for patients with mild disease or not for patients even with moderate disease, particularly for inpatient or outpatient with severe ulcerative colitis. So in that recommendation, so also recommend against the use of steroid for maintenance of remission. So you should consider other alternatives rather than putting the patients on maintenance steroid. And for patients with acute severe ulcerative colitis, the maximum durations of IV steroid to be used before consider switching to rescue therapy is actually 5 days. So I think there's a very fixed limit, that time limit, that you should consider escalating treatment without delaying the appropriate management in these patients with severe colitis, where time is actually crucial. What about the role of immunomodulators? Unfortunately, I think if you look at most guidelines, including this ECHO recommendations just published this year, immunomodulators, particularly valpirines, as monotherapy for induction of remission, there's no benefits. It's actually recommend against the use of valpirines for inductions. For maintenance of remissions, but only in patients with steroid-dependent UC or those who are intolerant to 5-FU. So it's a very limited role of immunomodulators in management of UC nowadays. Now we have so many biologics available, apart from anti-TNF that we have been used for more than 20 years now. We also have vedolizumab, which is a very gut-selective, very safe biologics. And we also have ustekinumab, which target interleukin-23, proven to be useful also in ulcerative colitis, with other generations of interleukin-23, which is more specific. Ustekinumab target both interleukin-12 and 23. These newer generations are more specific to interleukin-23. We also have these oral form of small molecules, particularly JAK inhibitors. Tofacitinib is already been approved. Upadacitinib also approved for treatment, and also there's SP1 inhibitors, the ozanimod. So there's so many to choose from which one we should use. I think this is a very difficult question, except perhaps in acute severe ulcerative colitis, where infliximab is still considered the best biologics in patients with very severe ulcerative colitis. For patients moderate to severe or mild to moderate disease, I think there are many different choices you can think about. Not only the efficacy, but also sometimes we consider safety, the mode of actions, the onset time, whether you need very acute rescue of patients or the patient can wait for a few weeks for the medication to work. And also the route of administration, particularly during COVID, many hospitals are closed, so the IV medications may not be preferred by many. So subcutaneous and per oral medication has a very important role during the COVID-19 pandemic. And also cost is and availability is a major issue in Asian countries because of the limited resources. So the availability of biosimilars, the availability of even generic medication sometimes may be very useful. So unfortunately, there are not many head-to-head comparing different biologics. I think you're very familiar with vedolizumab comparing with adalimumab, but other than that, is there any other data? So this is a very recent summary of real-world studies comparing the effectiveness between biologics in TNF-naive UC patients. You can see that most of the studies did not find any difference between anti-TNF and vedolizumab in real life. And although infliximab seems to be better than adalimumab in preventing hospitalizations. But other than that, I think so far, apart from that randomized control studies, most of the real-world studies cannot show which one is actually better. So this is again a oversimplified table or figures trying to show you the role or the efficacies of different medications in treating inductions of remission in patients with UC. And you can see that infliximab is usually slightly better than adalimumab. whether it's better than ustekinumab, I think we need head-to-head comparison, but vedolizumab seems to be not very, particularly in acute severe colitis, but they're very safe. They have been proven to be useful in UC. And the recent JAK inhibitors look very promising, not only because it's orally given, but they also have very rapid onset. Particularly upadacitinib seems to be relatively safe, and they also have very rapid onset in managing UC patients. So talking about JAK inhibitors, this is data from tofacitinib, which has already been approved for treatment of UC. Very similar to infliximab, they have very rapid onset. So by day 3, you see some response in terms of the symptoms, in terms of bleeding, in terms of diarrhea. They seem to have some benefit even by day 3. So this is very important in managing, particularly managing outpatients with acute severe colitis. But we also have to talk about safety profile, particularly in Asia. We know that we are prone to infection, particularly TB is endemic in this part of the world, which may anti-TNF sometimes may not be the first-line medication despite the efficacy to be used. And JAK inhibitors also have its problem, particularly they have increased risk of infections, particularly herpes zoster. They also have increased risk of thromboembolism as well. Interleukin and also vedolizumab seems to be relatively safe. Interleukin, vedolizumab, and also the 23 seem to be relatively safe, and the safety profile seems to be quite promising. So this is looking at serious infections with biologics. So comparing ustekinumab and anti-TNF, they found that particularly for Crohn's disease, there's about 50% low risk of serious infections with ustekinumab, although there's not much data on UC. When compared with vedolizumab with TNF-alpha, there's at least 32% low risk of serious infection with vedolizumab when compared to TNF-alpha. When compared ustekinumab with vedolizumab, unfortunately, there's not much data. With Crohn's disease, there seems to be low risk of serious infection with ustekinumab. So we still have a big knowledge gap in terms of safety, particularly in this part of the world. Unfortunately, I think European Medicine Agency just released these recommendations for JAK inhibitors this month. And they said that JAK inhibitors should be used very cautiously in elderly patients or patients with major cardiovascular problems or venous thromboembolism. So despite the very rapid onsets already about active, so these medication may not be very good for elderly patients with acute severe ulcerative colitis. So we talk about the route of administration, which is also important, particularly some patients do not want to be hospitalized during COVID. And also in Asia, particularly in India, there are many generic. Even tofacitinib have generic, which is very cheap. So whether this drug will be the first choice in some countries because of availability, because of cost issues, I think we need more data, we need more experience to determine. So ladies and gentlemen, in conclusions, my take-home message is monitoring of UCs will require a combination of symptoms or biochemical markers. Unfortunately, histological remission is still not something easily achievable at this moment, so it's still not a target, but this is the ideal endpoint that we can use. The optimal cutoff point of fecal calprotectin is yet to be defined. If you look at data, anything between 150 to 250 seems to be reasonable in prediction of clinical or endoscopic remissions. In resource-limited countries like Asia, I think optimization of non-biologic therapy, particularly 5-ASA and even topical steroids, should be given priority before we consider escalating to biologics. But this should not be delayed our treatment escalations because sometimes these patients cannot wait too long. And choice of biologic is getting more difficult and complex because of the availability of many other different medications and lack of data, particularly head-to-head comparison data. But again, depends on the severity of illness, depends on the safety profile, and also many other individual considerations or even economical considerations. So I think thank you very much, ladies and gentlemen. This is the end of my presentations. Welcome any questions and suggestions. Thank you.
Thank you very much, WK. for your fantastic and informative lecture. So there is one question from the audience. The question is, what shall we do in case of the patient resistant to biologic therapy for ulcerative colitis?
Well, I think it depends on the clinical situations. If it's acute severe colitis, I think the answer is very simple. Then they may have to consider surgery because saving life is always more important than saving the colon. So I think for acute severe ulcerative colitis, if they fail to respond to induction of infliximab, I think we should solicit help from our surgeons. For patients with moderate severe ulcerative colitis that failed to respond to one biologics, I think there are so many other choices that you may consider switching the patient to other biologics. Particularly if they just failed infliximab, they may consider switching to vedolizumab. If they failed vedolizumab, you may consider other alternatives like anti-TNF or even the interleukin-23 inhibitors, even the JAK inhibitors. Also, there's some emerging data suggesting that even combination treatment, a combination of biologics, usually with a much safer profile, like the interleukin-23 or vedolizumab as a backbone together with an anti-TNF. So I think there are many data nowadays suggesting that there are many other options available, but I think the key is still trying to prevent the use of steroid with minimal side effect. And also, I think if needed, sometimes you may still have to consider surgery in some patients.
Thank you very much. And I have a few questions that's very simple. Also go back to mild to moderate UC, which is the main point in this lecture. So as your lecture, the combination of oral and topical form is better than oral alone. So I'd like to ask, in your real practice, between oral plus enema and oral plus suppository, so which one that you use more frequently?
I more frequently use a suppository than enema, because enema, first of all, is more expensive. It is not very convenient to be used as well. So I think suppository usually much more the first choice. But for some patients with first refractory symptoms, I think enema sometimes works very well. So, and some patients refuse oral medication, we give them both suppository and enema as well. So I think it depends on different patients. Some patients are very, very reluctant to the use of enema as well.
Yes, thank you. I think so. And the second question, so when the patients get clinical remission, and we want, so we usually lower the dose of mesalamine to maintenance dose, as you show in your slide. So before you lower the dose of this medicine, apart from just clinical remission, do you require other objective evaluations like CRP normalization, carbohydrate normalization, or even endoscopic mucosal healing before you lowering the dose?
I think that's a very good question. So I think in terms of STRIDE 2 recommendations, before you consider de-escalation treatment, I think the patient at least should have clinical and biochemical remissions. I think it's up to you. If the patient have biochemical remission, may not require endoscopy remissions, but at least the fecal calprotectin or the C-reactive proteins should be normalized before you consider de-escalating the treatment. I don't think like the idea of de-escalating treatment too quickly, particularly if patients only symptomatic remissions. So usually I think you should wait at least they have biochemical remissions.
Thank you. And for the last question, in the patients with clinical remission with combination therapy, and because we want to bring down, so do you prefer to leave both regimens with maintenance dose for these patients, or you of one of them, like of oral or of suppository from maintenance period?
Well, again, depends on the extent of disease. Do the patients have
in distal colitis?
Very extensive colitis? I probably would not stop the oral medications. The patient only have proctitis, then maybe I will stop the oral medications. I think again depends on sometimes not only physician choice but also the patient choice as well, because I don't know whether some patients are actually very reluctant for the use of suppository. So, but you can ask them to reduce the frequency instead of doing daily, they may actually do 2 times or 3 times per week. So I think that is the recommendation. So again, depends on the extent of disease and also the patient's choice. Yeah.
Okay, thank you very much for a clear answer. Okay, I think our time is finished for this session. I would like to thank Professor Leung again for a very excellent lecture and very clear answering for all questions. And thanks Ferring again for organizing this symposium. And I'd like to turn the symposium back to the conference. Thank you very much, everybody.
Thank you. Thank you.